All right, guys, gals, let's continue our discussion on glands and membranes. This is part 2 of a 2-part recording for our Friday lecture series. Let's talk about how tissues grow. And this category doesn't really or topic doesn't fit really well with glands and membrane, but I'm trying to follow our textbook, so to speak, as we go through the course, for those of you who like to read along with the textbook. And since this topic is covered at this point in the text, or in this chapter of the textbook, let's hit it. So when we think of tissues growing, generally speaking, we need the cells to get larger, so they're going to increase in size, or we're going to increase the number of cells. And there's a couple different ways we can have tissue growth. At this point in my life, I want more hypertrophy. When I think of hypertrophy, I want to enlarge my pre-existing cells. And really, when I think of hypertrophy, I'm thinking of my skeletal muscle cells. I want bigger abs. I want bigger biceps, so to speak. Unfortunately, I also have my adipocytes, or adipocytes, that are also enlarging as I'm approaching middle age, which is kind of unfortunate. Something else occurs. We have cell growth or tissue growth through cell multiplication. Some of this is very natural and very healthy. Think of your skin regenerating itself after you have an injury, or the lining of your stomach regenerating itself. We have hyperplasia. Plasia for multiplication, trophy for an increase in size. So as we look at hyperplasia, that'll be increased through the number of cells. And hyperplasia is good cell multiplication. If we have unwanted or bad cell multiplication, we call that neoplasia. Neo meaning new. This new growth is going to be considered a tumor, this new unwanted growth. Now, if it's benign, it's not going to be growing and spreading very quickly. If it's malignant, it's going to be growing rapidly and spreading rapidly throughout the body. Kind of like the difference between a cancerous and non-cancerous tumor. So as we look at those tissue types in our bodies, as our tissues are growing, they're going to change what kind of tissue we're looking at. You can think of it kind of like a technology tree, where at the beginning we have all tissues in our body looking identical. And very early on in embryonic development, we differentiate through the 3 different kinds of mesenchyme. We have the ectoderm, the mesoderm, and the endoderm. And as those different parts of our mesenchyme differentiate, they're going to further differentiate into all the other tissues of our bodies. Now, when we think of this process of differentiation, we're going to see that cells go from immature cell types, so either an embryonic stem cell, or excuse me, we could say a totipotent stem cell, a pluripotent stem cell, or a multipotent stem cell, to the final adult cell stage. So this process is going to be going from a general to a more specific tissue type. When we have metaplasia, metaplasia is going to be one cell type going from one kind of mature tissue to another kind of mature tissue. Metaplasia is going to be your metamorphosis, your changing of form. I love reading science fiction and watching science fiction. So, in those classic science fiction movies where somebody's infected by a virus and they go from being a human being and they turn into the reptile man, that would be an example of metaplasia. Now, in our own human bodies, we have metaplasia occurring all the time. A good example of this, both natural and unnatural, would be if we look at the vaginal lining. Before puberty, we have a simple cuboidal lining of the vagina. And when we think of the simple cuboidal lining, this is going to be a one-layer thick, or one layer of cells that's cuboidal in shape. So if we think before puberty, generally speaking, there should be nothing in the vaginal canal. So there's no need to have multiple layers of cells to resist abrasion. However, after puberty occurs in young ladies, what we find is that all of a sudden we need to get ready to be sexually active, and we go from that simple cuboidal to a stratified squamous layer. Stratified meaning multiple layers, squamous meaning flattened cells. So we go from a layer that's not designed to resist abrasion to a layer that is designed to resist abrasion in the vaginal canal. We also find that with smokers, the pseudostratified columnar epithelium of smokers can morph if they go through a lot of smoking, if they smoke. Normally we have pseudostratified columnar epithelium with lots of cilia present. and goblet cells, and that removes the debris from the lungs. However, people that smoke a lot kill off, or not kill off, but cause that ciliated pseudostratified columnar epithelium to morph into a stratified squamous epithelium. And then they lose the ability to remove as much particulate matter from their lungs as they used to have. And that's why we have a lot of things like smoking cough. Now, when we think of a stem cell, this is a kind of cell that all other cell types or tissue types ultimately will stem from. So the stem cell is going to be an undifferentiated cell, and there are degrees of undifferentiated cells, or there's degrees of flexibility within our stem cells. We have super flexible and sort of flexible stem cells. This flexibility of the stem cell to morph from one cell type to another cell type is called developmental plasticity. So stem cells with lots of developmental plasticity are more flexible and can change into more tissue types. Stem cells with less developmental plasticity can only change into a few predetermined cell types. So we're going to camp on this slide for a little bit here. We have totipotent, pluripotent, and multipotent. These are the big categories of stem cells. For those of you who are getting up there in age like me, you may remember in the 2000s, there was a lot of controversy in the news about funding for stem cell research. And one of the things that bothered me about all these news articles that talked about stem cell research is they treated all stem cells the same. But there's a lot of differences, both in terms of application and harvesting and ethical implications of our stem cells, whether they come from an embryonic source or an adult source. When we think of embryonic stem cells, most people think of pluripotent stem cells, although technically we also have totipotent. Totipotent is the single most flexible kind of stem cell type. It has the most developmental plasticity. Totipotent stem cells have the most plasticity. They can become anything in the human body or outside of the human body. And you're probably thinking to yourself, whoa, wait a second. What do you mean totipotent stem cells can become something outside of the human body? I'm not talking about like, extra appendages or, different kinds of animals. When I say outside of the human body, I'm referring specifically to the placenta. So before differentiation, that early embryonic stage with the blastocyst is going to embed in the uterus. Some of the cells are going to form the amniotic sac and the placenta and the umbilical cord, which after birth, after you're born, you cut the cord, and those are no longer part of your body. That's what I mean by outside of the human body. So the accessory organs of pregnancy. Now, we don't necessarily care that much per se about totipotent stem cells because they're a little bit more difficult to harvest. However, pluripotent stem cells, those are a little bit easier to harvest, and they still, pragmatically speaking, give us what we care about, because we care about cells that can turn into any tissue of an adult human being. So in many respects, from a research perspective, unless you're trying to make a placenta, or if you're trying to make an amniotic sac, you might not want to harvest totipotent stem cells. Harvesting the pluripotent stem cells will make it so that the cells that you harvest probably are not going to turn into a placenta because they've lost some of their developmental plasticity. Now, when we think of these embryonic stem cells, these are the most flexible cell types. They have the most flexibility or developmental plasticity. We also have adult stem cells. They're not fully differentiated yet. And we find these adult stem cells in mature organs in adults and children. When we look at they are going to be considered multipotent or unipotent. Unipotent is not very common. A unipotent stem cell is going to be a stem cell that can keep reproducing indefinitely, but only produces one final tissue type or cell type. And the classic example is going to be within the testes. We have some little tubes called seminiferous tubules, and we have cells. We have unipotent stem cells that make lots of sperm and only sperm. Most adult stem cells are multipotent. They can differentiate into a few different tissue types. Not all tissue types, just a few different tissue types. For example, we have multipotent stem cells in our bone marrow, and those multipotent stem cells in our bone marrow can turn into different kinds of blood cells. We also have multipotent stem cells in our skin that can turn into different tissue types in our skin during wound regeneration. This was not in your textbook, and I just had to add it. This is a big deal, and I'm really surprised that it's not in your textbook, because these induced pluripotent stem cells have been around for well over a decade. I remember back in 2012, I took a group of my high school students to a camp at UW-Madison, and we made induced pluripotent stem cells and then worked with them for tissue and culture regenerations. The idea behind an induced pluripotent stem cell is that you take an adult stem cell or a multipotent stem cell and then you reprogram it to behave just like a pluripotent stem cell. And I get really excited about induced pluripotent stem cells. And here's why. When we look at totipotent and pluripotent stem cells, these stem cell types offer you the most potential and flexibility in terms of research, but there's a big catch-22. You have to harvest them from an embryo, and a lot of individuals have ethical objections to harvesting and destroying embryos. Adult stem cells, on the other hand, there's no ethical objection to taking a skin sample or a small tissue sample from an adult, because you don't kill the adult in the process. The downside of the adult stem cell is that they're multipotent. They are not as flexible and don't hold as much potential as the pluripotent stem cells. And that's why I get excited about induced pluripotent stem cells. We can have our cake and eat it too. We can have no ethical considerations that are associated with those pluripotent stem cells, harvesting the pluripotent stem cells. And they perform just like pluripotent stem cells. What does this mean? This means from a patient perspective, you can harvest a skin sample from somebody, take that skin, the cells from their skin, reprogram those cells, and use them to make a custom-designed liver, a custom-designed kidney, custom-grown organs that are genetically 100% compatible with the patient. That's why I get excited about induced pluripotent stem cells. Let's talk about how we repair tissue damage in our bodies. We are two big ways. We can have regeneration and fibrosis. We all want regeneration. And when you're younger, you can have a lot of tissue regeneration. We replace the dead or damaged tissues with the same cell type. It's a one-to-one replacement. So we have complete restoration of function. We don't lose any function, so to speak. However, as we age, we lose the ability to regenerate our tissues. And instead of regenerating, we instead make more scar tissues. We go through fibrosis. So if I lose some skin cells, instead of making more skin cells, I'm instead going to make a bunch of collagen fibers that just kind of hold everything together. Fibrosis is going to happen even in young people if there's a very severe injury, but as we age, minor injuries will also be fibrosed instead of regenerated. So let's look at a small, simple skin wound. So here's a lady, she's cutting some vegetables and she slices her finger. And as we look at this injury, she perforated the epidermis with the stratified squamous, and then she went down to the dermis with its denser regular tissues, down into a blood vessel, sliced open the blood vessel, and blood came pouring out of the wound. She's bleeding. There's a couple first steps that occur when we have a wound and we want to go through both, either regeneration or fibrosis. First, we have some mast cells in our skin. And these mast cells that we talked about briefly are going to be present in high concentrations in our connective tissues. These mast cells release a chemical called histamine. This histamine causes blood vessels to dilate, and it makes our capillaries more permeable. What does this mean? This means that we can send more reinforcements, more troops, so to speak, to the site of injuries. As we have our blood plasma weep into the wound area, that blood plasma is going to carry two very key things with it: antibodies and clotting proteins. The antibodies help to neutralize any potential pathogens that may be invading through the injury. The clotting proteins help to stop the flow of blood, particularly blood cells, out of the wound. So now we're going to have a blood clot form. We have those fibrous proteins being secreted into the injury site. They form a clot. The clot is going to be kind of like a biological band-aid. And what the clot does is it forms a fibrous mesh of proteins. And this network of proteins is going to serve as the foundation for regeneration, or I should say for making new cells to fill the injury site. Now, this injury site is going to have a lot of pathogens and cellular debris present in it. So we're going to have the big eater cell, a macrophage, will eat the pathogen, so to speak. So we'll have a lot of macrophages delivered to the site of the injury. Those macrophages will then start to destroy or swallow and remove debris from the site of injury. After the macrophages have removed the debris from the site of injury, we are going to have capillary regeneration down in the dermal layer or the connective tissue layer. We're also going to find that in the epidermal layer or the surface layer of the cut, we're going to have regeneration of the stratified squamous epithelium. There's a cell type that makes fiber called a fibroblast. The fibroblast is going to deposit collagen both near the surface and down in the deep dermal layer. And this process of making new fibers, if we're looking at a timeline, typically will start no sooner than 3 days or 72 hours after the injury. But depending on how healthy you are, it could be done in as little, and also depending on the extent of the injury. This process can be done within 7 days or last up to 14 days. And then as we continue regenerating the epithelial cells and epidermis, so we have our stratified squamous epithelium regenerating up here. Underneath, we're going to have fibrosis occur. So this individual is not having complete 100% regeneration. The epidermis is going to reform, so there'll be regeneration of the epidermis, but down in the dermis, she's not going to have complete regeneration. Instead, we'll have fibrosis occur. Now, this fibrosis process, the scar tissue, sometimes you can see it through the surface of the skin, and some people are more prone to fibrosis than other people. Think of individuals that have three-dimensional scars or big bulging scars that form. And then this whole entire process will slowly heal. So if you look at this fibrosis or scar tissue, over a long period of time, there still can be regeneration. This can last up to 2 years. But if you've had a scar for 2+ years, there's really at that point no expectation that the fibrous tissue present in the scar is going to continue to regenerate and have original function restored. So that was tissue repair. Let's talk about tissue degradation and death. When we have a tissue get smaller, it's atrophy. Earlier on in this presentation, we talked about hypertrophy, tissues growing either through the cells getting larger or cells multiplying. We can have atrophy the same way. The cells themselves can get smaller, or that we can have a reduction in the number of cells. And there's two kinds of atrophy that occur in our bodies. One is just the normal atrophy of aging. As we get older, we lose neurons, unfortunately. Yes, we lose computing power as we get older, which is kind of depressing when I think about it. We also have disuse atrophy. This is the one that you can do something about. This is why this is the use it or lose it atrophy, where if you are a couch potato, your skeletal muscle fibers, generally speaking, are going to reduce in size and the tissue will become smaller. Now, these kinds of atrophy, if we have disuse atrophy or atrophy through aging, so senile atrophy, those are normal parts of life. However, we can have a homeostatic imbalance. We can have some kind of a disease state set in. Sometimes it could be an injury, sometimes it can be a chemical, sometimes it could be a pathogen. And that's going to cause tissue death. And we call tissue death necrosis, necro being a root word for death. Think of a necrophile, somebody who loves dead people. Necrosis is death of tissues. And there's two big ways we can have tissue necrosis. We can have an infarction or gangrene. Infarctions are when we have a blood supply cut off. The most common infarction you're probably going to hear about is a myocardial infarction, also known as a heart attack. when we have a blood vessel in the heart blocked, and then when that blood vessel of the heart gets blocked, we have a supply of blood cut off to the heart tissue, and the cardiac muscle tissue starts to die off. We also could have gangrene, and this gangrene is not going to be from a complete cutoff of blood, but is instead due to an insufficient supply of blood. And there are different things that can cause gangrene. We could have bed sores. Bed sores, also known as a decubitus ulcer. This is when we don't move around enough. If we're stationary too long, we can have pressure points build up, and these pressure points can pinch off the blood flow and cause tissue death. We can have dry gangrene. This is going to be a situation where the individual's blood capillaries start to break down, and even though they're still walking around, they're moving, they're not stationary like somebody who's bedridden, they're still going to have a reduced amount of blood flow, particularly to the extremities. This is dry gangrene is going to be a situation where you'll see individuals with type 2 diabetes getting their foot amputated or their lower legs amputated frequently. We could have wet gangrene. This is typically going to be when an infection, or a pathogen, I should say, starts to digest the organs, and we have liquefaction. So we have the pathogen liquefying or destroying and digesting tissues of our internal organs. Or we could have gas gangrene. Gas gangrene is not terribly common, thank goodness. We're going to have bacterium in our bodies going through anaerobic respiration, producing hydrogen bubbles, and those hydrogen bubbles themselves will build up and reduce the flow of blood in our blood capillaries, leading to the gangrene. There's another way that our tissues can die, and that's through apoptosis. Apoptosis is a good thing. It is a good thing when a cell of our body decides to kill itself. And you're probably thinking to yourself, oh my gosh, no it's not. I don't want my cells to die. But there's a catch-22. If the cell is going to be killing itself, it has a really good reason to be killing itself. Generally speaking, cells go through apoptosis for one of two big reasons. Either that cell is going to be a precancerous cell, and instead of turning into a cancerous tumor, apoptosis is initiated and it's eliminated from the body. That's good. That's very good. Another common reason that we have apoptosis in our bodies is that a cell is infected with a virus, and instead of having that virus take over the cell and reprogram it to make more virus particles, the cell says, not going to happen. I'd rather die than make more virus particles. And the cell kills itself via apoptosis. The third way in adults that we have apoptosis is cells disintegrating as tissues are being removed and we are making room for other tissue types. So think of people that are maybe gaining a lot of weight and then they lose a lot of weight. If there's large fluctuations in weight, there can be some apoptosis associated with that. When apoptosis occurs, the debris associated from that degradation of the cells needs to be phagocytized by macrophages to be removed from the extracellular matrix. And when we think of this whole process of apoptosis, we happen to have it happen billions of times every day. To initiate apoptosis, there's some different ways. We could have an extracellular suicide signal bind to the FAS, the FOS protein. Once that FOS protein is activated, we're going to have enzymes inside of the cell, known as an endonuclease, go up to the DNA and turn it into spaghetti. It's going to chop up the DNA, dice it, and destroy the DNA. So we lose the instructions to keep the cell alive, and then we have proteases released into the cell that destroy all the proteins that keep the cell alive. So once we have the kill switch activated, the cell can kill itself multiple ways, by destroying its proteins and by destroying its DNA. It's a 1-2 punch. I should emphasize that right now, an active area of anti-cancer research is to re-establish the kill signal, the suicide program of the cancerous cells. When a cell becomes cancerous, it's a cell that should have initiated the suicide program, but instead instead did not initiate the suicide program, and instead began replicating out of control and became kind of a problem for the body. I'm really going to date myself here, but I'm going to use the Matrix as a reference point. Think of Agent Smith in the Matrix. Instead of Agent Smith going to be deleted, Agent Smith when he was just beaten by Neo and Morpheus and Trinity in the Matrix. Agent Smith said, no, I'm instead going to start reproducing myself instead, and became a problem. The same is true for those cells that are cancerous. Instead of initiating their suicide program, they instead go through rapid cellular divisions and become a problem for our bodies. That's all for our recording today. This is part 2 of 2 on epithelial tissues and glandular secretions, even though the second half of this presentation was really mostly about tissue regeneration. If you have any questions, please feel free to shoot me an email or swing by my office hours. And as always, happy studies.